All right. Welcome, everybody. Happy Friday. We're going to let a few people pop in, so it'll be a minute or two before we get started. Um, I just put in the chat, feel free to drop any questions there as we go. Speakers will do their best to answer them live or at the end. I'll just give another second or two. All right. Well, we've hit 11:01, so we'll just go ahead and get started. All right. Hi, everyone. My name is Hannah Nixon. I'm Director of Marketing here at TCare. So excited to have you all on. I see a lot of super familiar names. I'm excited for you guys to join us today. Today's session looks at how care management is moving into the home and what that shift means for health plans and our care managers and provider organizations. I'm not going to spend too much time giving you all the intro and all that jazz. I'll let Ken and James do that. Like I said before, if you weren't here just a second ago, feel free to drop your questions into the chat and we will answer them live or at the end. There will be a follow-up email afterwards with the recording and the slides. So if you can't stay on for the full length, don't worry, we will send it to you afterwards. So with that, I'll turn it over to Ken and James to kick us off.
Kelly, thank you so much, and Kelly and Hannah at TCare for giving us the opportunity today to talk to you about extending care management into the home. I am old enough where I'm an analog guy living in a digital generation, so if all of you will permit James to change the slides when I ask him to do that, like now, that would be terrific. So first of all, I'm Ken Peach. As Hannah mentioned, I began a 40-year broadcasting and healthcare career as a volunteer first responder in New Jersey. But more recently, I created the community paramedicine program that brings care management into the homes of over 30,000 Central Florida residents. And with me today is, it's coming up on 23 years as a paramedic, James Witherspoon, and he's worked in both urban and rural settings. He's also certified in Florida as a community health worker, and we'll be focusing today on the role of paramedics and community paramedics and community health workers as it relates to going into the home. Next slide. So we're going to share with you today some true stories that we and our team members have experienced since beginning this journey. We started as a nonprofit community paramedicine program in 2017. These stories will allow us to pass along some ideas and approaches that we hope will help you and enable you to extend your care management into the homes of your communities. James? So we did mention, as Hannah did, to please place your questions into the chat as we go. What we'll be doing then is responding. We've left some time at the end to go ahead and go through those. So I'll be checking those a little bit later on, and we'll bring those up so we can answer your questions at that point in time. Next slide. So we're going to start out with a rather sad discovery, but it has a happy ending. This is back in 2018 when we were just getting our care management in the home program underway. And I say care management in the home because when I spoke to two physicians early on, when I was getting this program started, I said, you know, what is, in this case, community paramedicine? And they said, well, that's the guys that come on the trucks. Well, first of all, I said we're not all guys. Second of all, we don't have trucks, we don't have ambulances. So it's a different approach altogether. I said, what about case or care management? Oh, we understand what that is. I said, well, this is field care management. And that's the way we've approached this ever since when we talk to physicians, because what we want to do is share with them that it's really all about care management. So Chris had responded, and go ahead, next slide, James. We received a request actually from a local hospital to investigate why an elderly woman was coming into the hospital every 2 to 3 days into the emergency department, but she had no obvious injuries or illness. And so Chris, as our paramedics tend to do, went back out. He noticed when he arrived that she had no food. So he went out, bought food, stocked the kitchen for her. He went back 2 days later, and that's when he realized that this elderly woman was no longer living alone and not by her choice. Next slide. squatters had actually moved into the apartment across the hall from her, or down the way. And then also, in addition to that, had moved into her apartment, were proceeding to eat her food and take her money. So needless to say, we had to take some quick action. We notified elder abuse. We notified the landlord. They changed the locks, chased out the squatters. And lo and behold, she didn't have to go to the emergency department every 2 to 3 days. She didn't have to use the 911 number as a safety method. So that really opened our eyes, and James will start to share with you some things about what makes a good care management extender.
All right. So a lot of our paramedics are cross-trained as both community health workers and community paramedics. And the community health worker is a frontline worker that is a trusted member of the community. And this relationship enables community health workers to serve as a link between services and the community and improve the quality and competence out in the field. CHWs go by many names: Promotores de Salud, care coordinator, peer educator, navigator, community health advocate. Those are just some terms for community health workers. But they serve very many roles. They help with navigating complex insurance applications, finding food assistance, accessing services for older adults or family members living with disabilities. They also help to educate and screen for chronic health conditions and much more. CHWs are excellent at active listening, and they recognize the dignity of all of their clients. Also, we have community paramedics that help to integrate care systems and engage with other healthcare practitioners, organizations, community-based services, and others with a shared commitment to improving the healthcare access and outcomes and reduce disparities in cost. Community paramedics help to mitigate costs through collaboration with primary care providers. They often use telehealth, which in turn supports better communication with the patient and the care team. This collaboration can also increase the use of preventative care, help with medication adherence, reduce hospital readmissions, prevent the overuse of 911 and emergency department, and it often leads to improved outcomes, which can in turn result in cost savings and a better return on investment. So some of the things community paramedics can do, they can help reduce blood pressure and hemoglobin A1C levels. That helps to reduce rates of 30-day hospital readmissions. It also prevents unnecessarily ambulance transports, ER, and increased communication between the patient and the care team. They accomplish this by addressing social determinants of health and reducing barriers such as transportation, scheduling issues, improving patient engagement, and promoting patient-centered care, which also improves patient satisfaction as well.
So since 2017, we've learned and implemented a number of ways to use our home visits to enhance care management. And James is going to share the first one with you that occurred actually with COVID.
Yes. So when COVID hit, a lot of patients were having symptoms and oftentimes would end up in the emergency department, admitted to the hospital. Some were showing up at clinics, urgent cares, their doctor's office. And of course, COVID was something you didn't want spreading out into the community. So we actually had one of our contracted clients that started asking us, hi, we have patients that are contacting us that want to come into our office that think that they might have COVID, but we don't want to expose all of our other patients and staff here in the clinic to a possible COVID infection. So they outfitted us with COVID test, strep test, flu test, and they would send a referral over to us, and we would actually go out to the patient's home and through point of care testing, test them for COVID, strep, and flu. And if the patient tested positive for any of this we would relay back to the office, and then the provider could in turn call in the prescriptions to the pharmacy. And that was instrumental at keeping those patients home and giving them the tools that they needed to weather, the COVID virus, or whether it was flu or strep. And so our client was very happy about this type of situation that we had.
And, another unique situation that works off that is also another COVID related, and that was in the next slide, that for over a year, funding from the Florida Departmental Disabilities Council in conjunction with the Well Florida Health Council in Florida enabled a specially trained community paramedic to get to know individuals who were intellectually and developmentally disabled. That paramedic would make repeat visits to the home of each individual to build a relationship with both the individual and with his or her caregivers. Now, one of the functions beyond building that relationship, which was very important, was to enable vaccination for COVID. So while much of the visit focused on building that relationship, and we actually were able to provide COVID vaccinations during that time as well. So as you can imagine, this put a lot of pressure on the caregivers who had needed to be addressed as part of the care management component of the home. So it gave the paramedics a chance not only to provide from a clinical standpoint, but also to understand some of the stresses and issues that the caregivers indeed were encountering themselves. Next slide. Other occurrences where we used care was when we needed to take care to the patient as opposed patient to the care. This was occurring where a local orthopedic physician, one of our early adopters of community paramedic home visits for care management, recognized the advantage of having someone enable him via telemedicine to ensure that his patients were both prepared in advance for surgery and then were also later recovering safely at home. So similar to other home visits, and in many cases, these were 25% clinical in the time, 75% care management, because it's so much of what the paramedics or the community health workers find when they open the door to a home. And certainly that expands the awareness of the issues that may be there that are hidden really from the doctor's practice or from the opportunity for even telephonic care management, because suddenly we see things going on in the home that we're not aware of. So I'll ask James now to tell you how the community paramedics use telemedicine.
Yes. So once again, as I said, with the COVID testing, sometimes patients will call into their primary care doctor or the clinic and say, "Hey, I'm not feeling well today." And usually the primary provider will say, "Well, okay, come on into the office and we'll check you out." In certain circumstances, the patient will elect to stay home. And at that point, we can get a referral from the clinic and say, "Hey, we have this patient that isn't feeling well. They're refusing to come into the clinic to be seen. Is it possible for you to go out?" And so we do have the capability of same-day visits in which we will go out to see the patient in their home. We'll do a head-to-toe assessment, check vital signs, blood sugars, things of that nature. And sometimes we'll get the physician or the provider on through telemedicine, either through like a laptop. We've even used FaceTime in some cases, and literally puts the provider on with the patient. They can talk one-on-one. And then the provider will usually ask the paramedic, "Okay, what are you seeing and hearing out in the field?" If the patient has maybe a wound or something like that, or like a Foley catheter that needs to be checked, sometimes the provider will ask to see that on video. So we're essentially the eyes and ears of the provider inside the patient's home. And so that really bridges the gap between a patient who has some sort of an acute issue that would have probably ended up in maybe the emergency department or maybe even admission at some point. But instead, we're able to connect them through telehealth with their provider.
Well, care management in the field actually addresses also the hidden problems. James has two stories, the sugar mystery and power out or not.
Yes. So one of our clients sent over a referral several years ago. And in the referral, it said that they had this patient that had been presenting with a high A1C for years. And every time the patient was in the office, the provider would always ask, are you eating well? Are you eating the right foods? What's your sugar intake? Are you staying away from carbs? And the patient always said, yes, yes, I'm eating all the right things. I'm not eating sugar. And so this had been a mystery for several years. And when we went out to actually talk to the patient in home, I sat down and got a brief history from the patient. And then I asked you to look in her pantry, her fridge and her freezer. And everything that I saw was, like she said, mostly healthy: fruits, vegetables, meats. And so I was a bit puzzled also. But during my visit, her daughter came in and asked, "Who are you and what are you doing here?" And as I introduced myself and explained who I was, I also said, "Well, the reason I'm here is because your mom's blood sugar or A1C is always high, and we can't figure out why." To which the daughter said, "Well, did mom tell you about the refrigerator in her bedroom?" And I said, "No, she didn't really mention that part." So the daughter said, "Well, follow me back to mom's bedroom." And when I entered the bedroom, there next to the bed was a dorm room sized refrigerator. And we opened it up, and it was just chock full of sugary foods. Things like guava nectar, peach nectar, flan, rice pudding, chocolate candies, peppermints. The entire refrigerator was just one big sugar storage house. So I got permission to take a photo of that. And after leaving, I wrote up my report. I included the photo and sent that over to the referring provider. To which I got a text message said, "James, oh my God, you cracked the mystery. This was the missing puzzle piece that we've been looking for years." So as a result, the provider was able to schedule the patient for like food and nutrition consults and really talk to her about cutting out the sugar and lowering that A1C. So that was the sugar mystery. I also have another story, what Ken calls power out. And this was yet another client that sent a referral over to us. And this particular referral was a patient who was elderly, morbidly obese, and bedbound at home. And the only time she ever left her home was in the back of an ambulance, usually on the way to the emergency room, where she would most likely get admitted and then would return home by ambulance. So during my first visit, I did my assessment. And on my first visit, I usually ask, "Is there anything that I can assist you with? Anything you're struggling with?" And I could tell that she was rather reluctant to tell me something. And so I said, "Whatever it is, just go ahead, lay it on me." So she pulled out a stack of papers, and she handed me a bill from Florida Power and Light Company. And she said, "I'm $750 behind on my power bill." And looking over the bills, I kept seeing imminent disconnect notices. So I knew that this was going to be a situation that was going to happen rather quickly. So I needed to act on it. Here in Florida, we have the Elderly Home Energy Assistance Program, commonly called EHEAP. And I asked her, with her permission, to apply for that program. So I pulled out my computer, we filled out the application, sent it in to Meals on Wheels, who administers the program here in our county. And a few days later, I came back to her house and checked with Meals on Wheels, and they said that she had been denied for EHEAP. So I called and checked, and it was because her driver's license was expired. So EHEAP said they had to have a valid ID. After that, I contacted the local DMV and I said, hey, I have a patient who is morbidly obese. She's bedbound, lives at home. The only time she ever leaves her house is in the back of an ambulance. I need her ID to be renewed. And they said, well, she has to come to the local DMV for that. And I said, that's absolutely not possible. So at that point, they suggested that I contact the state DMV in Tallahassee. So I called them. I was on a hold for an hour and 44 minutes before I finally was connected to a supervisor. And once again, I pled my case and said that, I had a patient that was bedbound that needed a valid ID. And the person on the phone said, well, she has to go to the local DMV. And hearing that, I said, you mean to tell me that the state of Florida DMV does not have any ADA accommodations for someone who's home and bedbound? And she said, no, we do not. So at that point, I went on the U.S. Department of Justice website and I filed an ADA complaint against the state of Florida on behalf of the patient. And I got a phone call about 2 days later. It was a Tallahassee number, and they said, hi, we received your ADA complaint. How can we help you? Once again, I pled my case, and the person on the phone this time said, that's not a problem. We can renew her ID over the phone. It'll just be $25. So since I already had them on the phone, I just went ahead and pulled out my credit card and paid the $25, which I know is a no-no, but I didn't want to miss out on this opportunity. And so they said she'll receive her ID in about 4 to 5 days. And so once she got her ID, she called me up. She said, James, I have my ID. I drove to her house, got her ID, drove to Meals on Wheels. Here's her ID. They pulled up Florida Power and Light website, paid the entire $750, and gave me her ID back, a receipt showing a zero balance. And I took it back to her and handed it to her, and I said, you have a zero balance. And she just started crying in front of me. And as a community paramedic, that is one of the greatest feelings in the world, is knowing that you have been able to help somebody that either doesn't have the resources or doesn't know how to help themselves. And that's what community paramedics do. I should also say community paramedics and community health workers, because we all, roughly do the same thing. But it's really nice just being able to go out to someone's home, sit down with them, take the time. This of course, patient took hours and hours on end, navigating through all these issues. And really, I tell everybody it's like an onion, just peeling back the layers until you finally get down to the root of the problem. Once you fix that problem, everything else is just better after that. So that's the end of my 2 stories, and it was a pleasure telling them all to you.
Thanks, James. Care management becomes more effective when it has the addition of the ears, eyes, and sometimes you hate to say it, but nose inside the home, and those stories of things that you find. So it's not uncommon to find hazardous accumulation of items too, and debris in a home. We have lots of photos of homes stuffed with newspapers stacked to the ceiling, and a hoarding, of course, obstructs access to exits in an emergency, as well as posing a real fall hazard. And it also gives some indication of cognitive issues as well for the individual that is in that situation. But I also wanted to share a quick story with you about community paramedic John, who arrived at a home in Deltona, Florida. And when he arrived, he had been told to come on in. Well, that was easy because the sliding glass door on the home was wide open. And he discovered that the gentleman he was seeing was visually handicapped, was blind. So he asked, how is it that you organize your medications? Because medication reconciliation is one of the things that, again, being in the home, the community paramedic can do. So he proceeded to do what's done in an assessment. James will be filling you in a little bit later with that information. But in the process, he had organized his pills by a dresser drawer. So that literally the top drawer was his morning pill, the second drawer was his second pill, and so forth, being visually handicapped. So John, the paramedic, was able to address and settle the issues that had to be done. But he said, what about this door being wide open? The gentleman that lived there said, well, I can't get it closed. Well, it was off the track. So again, as our paramedics do, as James has shared with you, and as we've mentioned before with Chris, in this particular case, he simply put the door back on track so it could be locked and secured for this gentleman, so that, again, he would have a safe home. So again, one of the stories of these things that we find constantly being out in the field. But there are some other things that we find, and I'm going to let James share that with you as well.
So of course, the role of a paramedic is we operate under protocols usually, but it can be pretty wide. So some of the things that we can do, is minor wound care. A lot of patients, when they get out of the hospital, have wounds that are needing to be checked on, dressings changed. Some patients have wound vacs. And so our paramedics have training in wound care and can work with the referring providers and case managers to help change some of these things in the house. The paramedics also focus on chronic medical conditions while they're in the home. Patients presenting with COPD, congestive heart failure, diabetes, high blood pressure. We go pretty in depth with educating patients when we're in the home. As Ken mentioned, we do a medication reconciliation with patients. We look through their pantries to see what they're eating. And we oftentimes will source blood pressure machines and scales for patients who have kidney disease and congestive heart failure. And just educating patients and doing some of these things inside the home is a great way of keeping them healthy and well and out of the hospital.
And James, I'm glad you mentioned the technology as well. We had an opportunity in one community that we serve. It's an upper income community. Most of the individuals have a smart device in their home. And we worked with the physician group there to develop a script for them so that the community health worker or the community paramedic, when they go into the home, if there's a smart device there, literally can use the script to put a reminder on there. For example, at 2 o'clock every afternoon, the smart device says, Jack, if that Jack is the person that lives at home, have you checked your blood pressure today? If not, please do that now. And if your blood pressure is above blank, and we would put a number in there, then please call paramedic Ron so that he can come out and work with you to address this issue. So that's a really neat idea that costs absolutely nothing and that we'd love to see expand. So next slide, I'll share with you that when should care management extend into the home? Since much of care management has been proven successful simply using the telephone and computer technology, when might it be most appropriate to add a community health worker or a community paramedicine home visit? For example, we have one community where we see over 30,000 patients in that community alone with 3 community paramedics. The ways we do that, and look at the next slide, is that there is a way to address it by risk. So in this particular case, 5% of 30,000 individuals is only 1,500. So each of the community paramedics in that community can make 30 visits per week or 1,560 visits per year. Focusing on high-risk individuals allows us to concentrate on those in the highest risk category. Doctors and office care managers also refer those in the rising risk category, however, with those that are most concerning health and social issues that, if not addressed in that rising risk population, will push that individual into high risk. We also supplement home visits with zone tools. If you don't use those, it's a great tool. These are the tools that look like a traffic signal that have green, yellow, and red. The green is, and they're diagnosis specific. These are available from the QIOs, quality improvement organizations affiliated with CMS. Quite often have generated these zone tools, and we use those a lot. They are great leave behinds because the individual will know if they're in the green, they're okay. If they're in the yellow because of a particular metric or indicator, then that's one where they call their paramedic. And if they're in the red, generally, that's not only a paramedic, but that's probably going to be a 911. So very useful tool. James, share with us as far as assessing individual needs.
So when we arrive at the house, we often, even when we get up, before we get out of the car, we'll look and see, does the patient have a safe living environment? Is there transportation outside? When we enter the home, we do a home safety assessment and a fall risk assessment. We sit down and assess the patient. We check their vital signs. If they're diabetic, we will check their blood sugar, blood pressure, their weight, if they're a CHF patient. So then we will do a medication reconciliation. We'll go over like food and nutrition education. There's a lot of things that are incorporated into a home visit. And all of that we put into a report and we report back to the referring provider or the case manager. In some cases, a patient, if they present with some acute findings, at that point, the paramedic can decide, is it appropriate to contact the PCP and schedule like an urgent office visit? Should this patient go to an urgent care if they have, like maybe a laceration or something like that, or maybe a common cold or something? Or should this patient go to the emergency room? Are they having chest pain? Is there bad shortness of breath, low pulse ox? Or would it be appropriate for the patient to stay at home and just have the like nurse triage line follow up with them? So paramedics are given that education and training back in school. A lot of them, after working on the ambulance for several years or in the emergency department, or even some paramedics work up on the floor in the hospital, they gain these skills and are able to determine the severity or the acuity of what a patient needs. And it's very helpful, in deciding and then communicating back to the care team as to what you think that the patient might need at that time. Okay.
James is going to show you next the example of the electronic visit records that we maintain. And he'll share with you some of the information that we collect in a complete assessment. This information, as he mentioned, is transferred back after every visit back to the care manager in the medical office and the referring office. But at the same time, it's an on-site examination as opposed to trying to collect kind of this information through an electronic means.
So what you see in front of you is our EHR, just our home visit form. Up at the top, we have our basic demographics. Then we have our vital signs that we collect. Next, you'll see the medications. We do a medication reconciliation on every patient, every visit. Oftentimes, if a patient has been discharged, we'll ask to see the discharge paperwork that is sent home with the patient. Oftentimes they don't have that. It ends up lost or uh, uh, wherever. So we ask that our case managers send over a home medication list whenever they send over the referral. And this will look at what the patient is supposed to be on upon discharge and what they're actually taking in the home. And we oftentimes find that patients are missing a medication or the home med list will say one dosage and the patient will have another dosage at home. Or we've found expired medications and in some cases boxes of medications that were never taken by the patient. And as you know, medication compliance is one of the hugest parts of keeping a patient out of the hospital. We then, of course, in the next section, put down the notes, what we encountered, what we saw, what we talked about, recommendations that we gave to the patient. If there was anything that we noted on the actual physical assessment, any resources that we have referred the patient over to in the community. And then we addressed, like social history, environmental history. We do a PHQ-9 health screening on the patient. And then at the bottom, we actually track how many ER visits, how many hospital admissions that they've had. And this, of course, is our way of keeping the patients out of the hospital for at least 30 days. And we want to keep them out permanently. So sometimes we'll, or in most cases, we'll visit the patient once a week for 4 weeks. But in some complex patients who just need that little bit of extra, we have the ability to go back, weeks after that, just to make sure that a patient has, acclimated back to being home, that we've addressed all the barriers, and that they have all the tools that they need to, continue being healthy and well. So this report is generated after every home visit. And we email this securely back to the referring case manager, often to save in the patient's EMR there at the hospital or doctor's office or clinic that's referred the patient over to us.
James, thank you. If you'll flip a slide or two forward here, we'll talk about the services that are required. James shared with you that we've been doing post-acute home visits with the assessment process he described since 2017. And for a time, we worked with a hospitalist group to conduct transition care management visits to their patients the morning after discharge. We assessed their clinical and home situation and then shared this with the hospitalist via a telemedicine link. Some primary care and specialty physicians, like the orthopedic doctor that I talked about earlier, use us to keep their patients out of the emergency department and hospital on a preventive approach. And now, based on our hospital at home experience over the last year and a half, our paramedics will be part of a team managing individuals at home who otherwise would have been in the hospital for a longer length of stay. So there's a variety of different approaches that we've been able to use over time to go ahead and keep individuals living independently at home. That's the biggest desire of most individuals as they age, is to maintain that independence. And we see this working with our community health workers and our community paramedics, making these home delivery services available to keep these individuals living independently as long as possible, or as we call it, happy, healthy, and home. Next slide. So from a business standpoint, my business partner and I must always consider how services will be reimbursed so that we can go ahead and provide the service we're talking about. Next slide. Beginning as a nonprofit service of a local health planning agency that I was running at the time, we followed the direction of the local community foundation. So an entity that's generally nonprofit is going to look to start most programs with grants, and that's exactly what we did. $800,000 actually in 5 grants that I was able to write So that got us started. But the foundation says the next step then is earned income. Generally, grants are not going to be repeated. So how is it that we then move forward from an earned income standpoint? And in our case, sale of the service to medical groups with Medicare Advantage contracts, self-insured hotel chain, and a utility company. And that's allowed us then to grow and expand on a sustainable basis. Then eventually we transferred to a for-profit partnership to access sufficient growth capital to keep our program going. I share that in one of my last months at the nonprofit, our payroll went from $14,000 to $47,000 in 30 days in order to expand based on a new clinic need, our new client need. And so as a result of that, we had to do what the foundation recommends. The third step is raise capital to expand and grow. So beyond those initial grants, what we've done is we've worked with community-based organizations like federally qualified health clinics, health plans, direct contracts with employers, and accountable care organizations. So my advice is look for organizations that appreciate significant drops in medical emergency ER visits, hospitalizations, and hospital readmissions, and the total cost of care. Because if you can change that, and we've dropped that by 48%, if you can make those improvements for those organizations that we now call value-based contracts or value-based care plans, that makes a significant impact on those organizations. And generally, we found that to be the best way to pay for the community health workers and the community paramedics program on an ongoing and sustainable basis. Next slide, James. So as we wrap up, I want to share with you that another story to kind of close out our stories before we open up for questions. And this was an individual literally tied to home. So our paramedic, when called to this home or referred by the physician to this home, arrived to find that when he got inside, this woman, elderly woman in a wheelchair, had a rope tied from her wheelchair over to the front door. Her front door lock was broken, and the only way she could feel secure during the day was to sit in the wheelchair watching TV and making sure that her door stayed closed. So again, what's the solution? The paramedic went out, bought a new lock, and reinstalled the lock in her home for her so she didn't have to be tied to the door. So literally, these are the types of experiences we've shared with you today. Every one of those stories that we've shared with you is a true story that we've discovered since 2017. So we'll go to the next slide. And I'm taking a look at some of the questions we have in chat. And one of them is, how do you determine who's at high risk and rising risk? We mentioned before that that's the way you can take community health workers and this care management piece out in the field and be able to expand and leverage the resources. None of us have all the resources we'd like. And so at this point in time, what we do is we look at a number of indicators. We look at certainly the number of emergency room visits that have occurred within a certain period of time, the number of hospitalizations, the LACE score. If you're familiar with LACE scores, that indicates the likelihood of having a readmission. They're used a lot in hospitals, but you can do a Google search and find a one-page summary of the LACE score. We also use assessments generally, and I don't recall directly which one this was, but I believe it's the American Federation for Family Practice or whatever their association is. And they have an assessment document available to you. So what we try and do is use assessments quite often. In our case, whatever care management department or care managers in individual practices that we're working with, we use whatever they recommend. And we encourage that because they're generally the ones that are going to be actually using these tools to identify who really needs the home visits that we provide. That's the answer I had for the first question. James, did you have anything on that one?
I did not.
Okay. We got another question here. As a clinician, how much time does the community paramedic spend during a home visit on social needs and how much on the living environment? James, what's your experience?
That I will happily answer. I tell everybody that I encounter about 75% of what a community paramedic does is case management, and about 25% actually being a paramedic, hands-on medical stuff. When we go out into the field, we're sitting there with the patient. We establish that relationship with them. Once they realize that we're going to be there for an hour or so, that's their opportunity to really open up and tell us what problems that they're having, what those barriers are. Sometimes it could be something as simple as, I've had patients give me a whole grocery bag full of medications. And I look at them and say, are you really taking your medicine like you're supposed to? And so we keep pill organizer boxes in our vehicles. And if a patient does not have a pill organizer, they are provided one. On my first visit with the patient, after giving them their pill organizer, I'll show them how to separate their medications. On visit number 2, I will have them do it while I guide them. Visit number 3, I'll have them do it, and I'll only pipe up if I see them making an error. And usually by visit number 4, they've learned it themselves. So that's just one, key piece of keeping someone out of the hospital is medication compliance. Then, of course, food and nutrition is another key factor in it. There's patients with high blood pressure or CHF or kidney disease. Is it something as simple as I can't tell you how many patients I've gone visited and walked in and they're drinking Gatorade. I've asked patients, well, why are you drinking Gatorade? Oh, because it tastes good and I don't like the taste of plain water. So I actually keep Crystal Light packets in my medic bag. And I can't tell you how many patients I've actually asked them for a picture and made them Crystal Light and shown them, this is sugar-free, this is salt-free, this is something that you can drink without, having all that extra sugar, all that extra salt. So, something as simple as that. And helping patients source food. I've directed patients to the local food bank, help them sign up for those services, just so they can have access to fresh fruits and vegetables, meat that doesn't come out of a can. This is all tied to those social determinants of health, and a lot of times we can just simply erase some of those barriers, and that's what's needed to keep a patient healthy. So yeah, that's 75% case management and 25%, I mentioned wound care, things like that, the actual hands-on part of it.
Thanks, James. There's another question came in. How do we find a service like this in my city is what somebody asked. Most community paramedicine programs are EMS based. We also find a lot of community health worker programs running in conjunction with public health in Florida. And so my recommendation there is check with your local fire department. I know we have individuals on from states other than Florida. Recently, the Department of Health generated a list of all the community paramedic programs in the state of Florida and by county. So you can actually go ahead and take a look. So certainly that's one way to look. Our program is a little unique because we're actually started as a nonprofit and today operate as a for-profit. But having been around since 2017, we've shared with you today, and James is a good example of our paramedics. Those that we use, they're not the newest paramedics, just having achieved their license, but they're those that have a great deal of experience. We have another paramedic that's working with us right now. He's over 40 years working in the Fort Lauderdale area and in Texas prior to that, and providing the service. So we look for individuals that have a different experience. We generally don't have trouble keeping our community health workers or our paramedics on board because this gives them insight that they don't get doing emergency calls. An emergency call, unless it's a frequent flyer in the emergency department, they may see them once, twice. They really don't get to know them. Whereas our paramedics also have the pleasure of getting to know the families and the caregivers. We did have one instance I'll share with you at one time where one of our paramedics went out on behalf of a congestive heart failure clinic and identified that this woman who had been discharged from the hospital for CHF had gained a great deal of weight, and he knew that she had to have that fluid removed or she'd end up as an emergency case. She wasn't at that point in time an emergency, but she would have been. Now, having gotten to know the family, the paramedic called the family and said, okay, she needs to go back into the clinic. And they said, oh, well, is there a way to do that other than using an ambulance? And she was mobile enough. Yes, he said, yes. And they said, well, good. We're going to send an Uber to her house and bring her in that way. And the paramedic got in the car, his car, and just followed her to the clinic just to make sure everything was okay. So there's an example again of how our program operates a little bit differently, but how looking at community-based answers may be the answer. And service expansion outside of our market to yours is also possible as we've grown over the time from just one county and one paramedic to a team of paramedics in operating in 6 counties in Central Florida. Let me just check. Here's a question. Is it possible to document visits using electronic medical records other than the one that we showed you, which is something that we developed in conjunction with our paramedics? And yes, in fact, our paramedics, James, for quite some time has worked with Epic. For one of our large clients, worked on the Epic system. And we have other paramedics that work on the Athena cloud. So literally in those cases, you can, depending on what system is being used by a particular referring source, sometimes you can make that link and allow that source and that to provide the information the paramedic or the community health workers needs to go into the home right through that system. I'm just checking. Okay, here's another one. Assuming that elderly individuals and couples prefer to stay living in their current home, what do you do to facilitate that from a care management standpoint? James actually developed a particular assessment looking at that. James, you want to share what you put into that assessment focused on just individuals trying to keep them in their own home?
Yeah, it's basically just a form that we put together using ADLs, and it talks about what patients need at home, what they're deficient in, things that we've found that they may need a little bit of extra help with. Sometimes, as we're doing these assessments at a patient's home, we'll come to realize that the patient is safe to stay at home, or if the patient can stay at home, with caregivers, or if a patient might need an assisted living facility or even a skilled nursing facility. So every bit of that is taken into account and put on our assessment form and then shared with the person that's requesting.
Arranging for regular home visits to community health workers and community paramedics have been of help to some of our local care managers to ensure that there's been no major lifestyle changes that have occurred. Even seeing a physician, if you were to see your physician every month, still that's a lot of hours, a lot of days between those visits. And so we supplement that a little bit with electronic devices. So we have individuals that are on remote patient monitoring. I mentioned the smart device scripts that we use for individuals that may have smart devices in their homes. We're considering remote therapy monitoring. We actually are looking at working with a company that does motion sensors with discrete cameras under the bed, so it identifies when an individual is up and how long, and if they're moving around. I used to, many years ago, install personal emergency response systems. So there's a lot of different technology that may allow an individual to live safely in the home. A few years ago, we actually had applied for a grant from the city of Orlando to help individuals as they age stay in place. And there were even devices at that time, so I'm sure they're still out there, that would check and shut off the stovetop if the stove was left on. And of course, there's sensor devices that can be put on doors and windows and so forth as well. So it's becoming easier for individuals to age in place, which is certainly one of the things that we want to encourage. And this also is helpful here in retirement heaven in Florida. For those of you in Florida, you'll know what I'm saying. And for those of you not, you probably know that this is a destination for many as they age into their golden years, myself included. As that occurs, the opportunity for someone to keep an eye on them when the family is still living in one of the other states to the north, for example, or out west, is very important as well. So using technology and using these checks on the home, whether it is something that has an immediate need or whether it's something instead that just occurs over time, is certainly, I think, a good use of moving care management from the home into this other setting.
And you mentioned technology. I'll add to that real quick. I cannot tell you the number of patients that I have helped get life alert devices ordered and installed in their homes and set up. Even technology like Amazon Alexa, where patients, if they fall, they can just simply call out and say, "Hey, Alexa, call so-and-so," or call 911. We've done that. Even Apple Watches. Apple Watch has fall detection. So some of the elderly patients that I've had that frequently falls, just by getting them an Apple Watch, if they're not able to, it can send out an SOS to their emergency contacts that are programmed into their phones. So the community paramedics are able to sit down and assist these patients with getting these technologies installed in their home and set up. So when no one's around, that patient can still be safe.
I saw a message and it disappeared. Hannah, did you capture that for us?
I see the message. I can read it out to you, Ken. Chi-Chi says, do you have resources to see patients who do not have a home but are high readmissions for hospitals?
Okay, if they're home, so in other words, would they be homeless? I'm thinking, is that okay? The nature of that question. There are organizations, and I'm sure every community has one. We have a number of them here in Central Florida that focus on serving the needs of the homeless. So these are organizations that quite often have individuals that are going into the woods and into those areas where there are no individuals. While we have never been in a situation where we have sent our community paramedics or our community health workers into that situation alone, we have the ability to team up with those organizations. And so I think the answer there would be yes, there's a way to make that work. And it's a great question for those who may have homeless living in their communities. Thanks for that question. If you go to the next slide, James, I think the clock's showing me about 2 minutes left. So I did want to, again, thanks to TCare, to Hannah, to Kelly for allowing us to use this webinar platform to share our experience using community health workers and community paramedics to extend care management into the home. Here's our contact information, and we always welcome the opportunity to connect with you or your organization to answer additional questions or to explore expanding our services into your community. So thank you all and have a wonderful day.
Thank you, James and Ken. This was awesome. Loved hearing all those stories. That was really great. And thank you to everyone who joined us today and participated. We really appreciate your time and your engagement. I did just put something in the chat box. We'd love your feedback. There is a survey there. You can give TCare your feedback, or you can give feedback to James and Ken. And then a follow-up email will be sent later this afternoon with the slides and the recording of the presentation. So if you have anything else, feel free to drop it in the chat, or else we'll end it today. Thank you guys so much. Have a great weekend.
Thank you. Thank you, everyone.
Thank you.